Thank you so much. So now we'll mostly be discussing about the blood cancer, and it's the topic has been said that curing the incurable. I think blood cancer is one of the more satisfying disease to treat. It's one of the more curable malignancies, but yes, we do face challenges in managing these difficult to treat diseases. There are certain subset of patients who tend to do poorly, and how some of the newer cutting edge therapies that is being now brought to India as well is transforming the care of these patients. So quickly let's understand from our esteemed panelists that what are some of the common cancers they treat in their practice, how the epidemiology differs for differing age groups, and how how the situation is compared to in a government setup as well as in the private setup when they have practice. So quickly starting with Dr. Pawan. So what are some of the common hematological when we talk about the hematological cancers, what are some of the common cancers you see in your practice and how their epidemiology differs according to the different age groups?
Yeah, so if you talk about as far as the data is concerned from India and from Western world also, the commoner malignancies are usually they are chronic malignancies, and the most common hematological malignancy in the Western data is CLL, but we don't see that is not commoner in our set of patients, and it is mostly, I can say, that CML, that myeloma it's a disease of elderly people, and chronic malignancies are usually more commoner, and acute malignancies like acute leukemias, whether it is lymphoid or myeloid, they are less commoner and more commonly seen in pediatric patients. Like ALL is more commonly seen in pediatric patients. Comparing government versus private, government usually, I don't know, we see in private settings, I would say that acute leukemias will be more commonly seen in private settings as compared to government settings. If you see, mostly because very few centers are having facility to treat acute leukemias.
True. So I think whenever you are working, when I am also an alumni from AIMS, so acute leukemias we used to see more frequently because they are the patients who require admission. They are the patients who are, as he said, that they require more intensive therapies, often requiring blood product support, antibiotics, and their few months of treatment are very critical. While a lot of chronic leukemia patients can be managed with some oral tablets as well, some of them don't even require treatment. So they are mostly seen in the outpatient setting. So coming to Dr. Subhaprakash sir. So if we talk about the survival rates for leukemia, so we'll focus on leukemia for now. So what is the survival of patients of leukemia in Indian setting, and how is it again different for different age groups, and how does it compare to the Western data that is available?
Yeah. So when we talk about the leukemia, so there is two leukemia we talk about, like acute leukemia, right? And acute leukemia is two types mostly: the acute myeloid leukemia and acute lymphoblastic leukemia. Dr. Gaurav is sitting next to us. He's a pediatric hematologist. So acute leukemia in the pediatric setup, almost 90% is curable. And that is the data. And we are also in a country like India, and in the private sector, we are already reached at 80 to 90% survival rate. So there is no survival gap, I feel, across the country it is there. Some logistical challenge may be there. What Dr. Pawan also told that private government setup, there are some challenges, cost, everything are there. But more or less, if the patient, the cost aside, if the patient is treated properly in our country, most of the centers do that, and our pediatric leukemia is extremely well. Adult leukemia, adult ALL, when we talk about, it is still ranging around 30 to 40% overall survival. But with the advent of the CAR T cell therapy and the more bone marrow transplant centers are coming up in the country, that gap is also very, very closely matched. Acute myeloid leukemia is a challenge, is always. Acute myeloid leukemia, you can see even the pediatric patients very less, but it's adolescent, elderly, and more super elderly, like 70 plus patients, you see that. I can give you my perspective little bit here. Last 10-15 years of our practice, we have seen there is a sea change approach is coming. Very simple. When I talk about acute myeloid leukemia and any people more than 60, previously what was the approach? 60 हो गया, अब घर भेज दो, हरि भजन करो और 3-4 महीना जिंदगी रहेगा. What Dr. Third told, I really appreciated that. That mindset should be changed in our country. And now we have a lot of non-chemotherapy approaches are coming. Mind the word, non-chemotherapy approaches. Non-chemotherapy approaches in acute myeloid leukemia, even elderly patients, we can offer that. Lot of targeted chemotherapy is coming up. What is a targeted therapy? You need just a specific some driver mutation or driver of a cancer. So you have to kill the driver. So I explain the patients like that. There is a bus is moving on. You have started firing over the bus. Many of the passengers died, but 1 or 2 tire may puncture, may not be punctured, but your driver is smart, the bus is away. But if you only kill the driver of the bus, not damaging not a single bullet fired on the bus, not a single passenger died, then you can very effectively, very efficiently, you can stop the journey of the bus. So that ideation we are getting much. So prognostications we are moving, targeted therapy coming in big way. Now we want to, like astrologer, right? Like acute myeloid leukemia when I talk about. So there is a mutation called NPM1 mutation. If you got a AML NPM1 mutation, we hematologists, me and Pawan will be extremely happy. We know that without transplantation, 90% patient will be curable. But if you get FLT3 positive disease, we are not very happy. Now we have FLT3 inhibitor is coming up. So now we want to understand and dissecting the disease. One AML patient, little bit chemotherapy, completely cured. One AML patient, given everything, bone marrow transplant patient relapsed. That means these are not same disease. Name is same, but it's different diseases. So that way we are now able to dissect the disease, and that definitely increases the survival. Another last point I want to say about the bone marrow transplantation that we are doing day in, day out. We are transplanters basically. So in India, still according to the population dynamics, in India, we do, according to our Indian Society of Stem Cell Transplant Registry data, 3,500 transplant we do annually at present. But if you the same population you match in the US, we are supposed to do at least 35 to 40,000 transplant. So that is the gap is there. But every year we are seeing the transplant centers are coming up, more talented doctors are coming up. I'm very sure another 5 to 10 years, that bridge also to be taken care of.
Very important points. So just 3 quick points I would like to make. I think we were treating acute lymphoblastic leukemia as a part of Icicle protocol at my institute. Dr. Samir Bakshi was our one of the co-investigators. So we have been able to reach a cure rate. According to that data, we have been able to reach a cure rate of more than 92% in pediatric ALL, and that is our Indian data. 95% cure rate is what the West tells us about. But still, the biggest challenge is that these are the patients who have already been included in trial and they have started treatment. So there are a lot of patients who succumb to the illness prior to even reaching the government hospital, even prior to starting therapy. That is the bridge and gap that we need to fill. We need to sensitize the population. We need to sensitize the general physician when to refer to the patients and how quickly this disease can become fatal. We have seen patients dying from acute leukemia within like 10 days of presentation. So we have achieved a lot of success in treating these patients, but we need to sensitize the general physicians who are referring these patients so that these patients can adequately or the timely reach the adequate facilities where they can be treated. Another point you said was that in the elderly setting, that how we are viewing elderly leukemia patients differently. I'll just give you a very quick example. It's a 90-year-old doctor. He's one of the very senior physicians. He came to me last year. He was diagnosed as an AML, and his wish was that I do not want to take any chemotherapy. I just want to continue playing cards and in between see patients. So we just told him that we are not going to give you any chemotherapy, like sir rightly said. Thankfully, there is one targeted injection. It had recently come in an oral form also. It's called tablet azacitidine. We told him that, okay, you take this tablet at home, just do your blood counts every 3 days and report to us. You will not believe it. He went into remission with that tablet in 1 month's time, and he continued to be remission for almost 10 months. Unfortunately, his disease has just started showing some evidence of relapse, but he never required to visit hospital. He continued taking that. Not even blood products were required for him. So it's not like a death sentence even for such patients, which we previously used to tell. So with that brings me to the next question to Dr. Gaurav. So how differently you are treating your pediatric patients in 2025 versus 2015 as far as leukemia is concerned, sir?
Yeah, so I mean, pediatric leukemias, as already highlighted by Dr. Sanyal, it has been a real success story. So in pediatric oncology, like 3 or 4 decades, 5 decades back, the success of pediatric leukemias. When I say pediatric leukemias, I'm specifically talking about acute lymphoblastic leukemia, which is more common in pediatric age group. Almost 70% of the pediatric acute leukemias are ALLs, and another 20 to 30% are AMLs. So for pediatric acute lymphoblastic leukemia, it has been a real success story. 5 or 6 decades back, the success rate was less than 10%. But nowadays, the success rate, as already highlighted, has reached almost 90% and beyond for majority of these standard risk or intermediate risk patients. So just like all other cancers, we divide pediatric leukemias also into different risk categories. So if we have a patient who falls into standard risk or intermediate risk, as highlighted, the success rate nowadays is more than 90% in any of the dedicated pediatric oncology centers. And I'm proud to say that this difference is not there in government or private hospitals. It's same across all the sectors. So if a patient is treated in a dedicated government hospital which has a pediatric oncology setup, there also the outcomes of these cancers will be the same as compared to if the patient is treated in any of the private setup. So that's something which is a major achievement, and that is on account of a lot of things. First of all, there are dedicated centers taking care of pediatric oncology, and that's a significant change which has happened in last sort of decade or so. In 2015, there were not so many pediatric oncology colleagues across the country. Now there are ample of pediatric oncology colleagues all across the country, and that has led to this improvement in overall care. And secondly, it's about how early we pick them, how better we categorize them into different risk categories, which helps us to decide the subsequent line of management. So a lot has changed in past decade or so, and because of these changes, the outcomes have in 2015 also, I would say they were not very inferior. The outcomes were approximately 80% or so across the country, and now we confidently say that it is more than 90%. The problem is the patients who do not fall into these standard risk, intermediate risk categories. For these patients, the options were limited, and majority of these patients used to die. But in past 10 years, what has changed is that specifically for this subset, we have beautiful targeted therapy, which my colleagues have already highlighted. So just like other malignancies, we have targeted drugs for pediatric acute lymphoblastic leukemia also, and they are just like too good, okay? And that has changed the way we treat these patients, and also changed the outcomes of these high-risk patients. A word was made about the futuristic therapy, CAR T-cell therapy, which is a phenomenal therapy. And fortunately, it is available in our country as well, indigenously developed by some centers, in license from by some other sort of companies. But the good part is that it is available, and the efforts are ongoing to increase the outreach of these therapies, increase the availability of these therapies, so that majority of patients can benefit with these therapies, which are more promising and have lesser complications.
Wonderful, sir. So, as Dr. Sanyal was also mentioning about the targeted therapy, Dr. Gaurav has also mentioned. So, I also treat solid tumors, and there is a concept called as a personalized medicine. What is personalized medicine? That every cancer is different. Every person's cancer is different. So much so, there is a concept called as intertumoral heterogeneity. Like the cancer which is being biopsied from one side, from two different sites of the same patient, that is also different. So we have tried to utilize this difference in the tumor heterogeneity by using certain targets, by using certain genetic testings, and we have been able to use personalized therapies in the form of tablets, some injections, to give a very good outcome. So My next question to Dr. Pawan will be, how has personalized therapy, we have seen its success rates in lung cancer. There are certain subsets of lung cancer, stage 4 lung cancer, they are also living for even 7 years, 8 years in stage 4 disease. How has this genetic testing or these targeted medicines have been incorporated into the treatment of blood cancers?
Okay, so we are talking about previously in previous talk, some speaker mentioned about precision therapy or personalized medicine. So basically, if we see in the past, so when we treated patients, तो हम ये देखते थे कि पेशेंट को सबको ट्रीट करते थे लेकिन सारे ठीक तो नहीं होते थे. Some patient used to respond so beautifully. कुछ पेशेंट को even after giving the best medicine available at that time, they usually don't respond. So then, because of the various studies and research, and especially in the cancer genetics and in the population genetics also. Like I'll give you an example. One patient you give medicine and he develops a particular side effect, the other person does not develop. So like sometimes we see some drugs like TPT एक TPMT mutation होता है, उसके लिए हम medicine देते हैं 6MP, उस पेशेंट के ब्लड काउंट्स ड्रॉप करते हैं, बट अदर पर्सन के नहीं होते हैं. So these are the, so one thing is about, first is studying about the cancer genetics, then studying about the population genetics. So population genetics will tell whether a particular patient will have, or even pharmacogenomics also, whether particular medicine is going to work or particular medicine is going to have a particular side effect on the person or not. Then other thing is, the main thing is that is cancer genetics. So when we study cancer genetics, we can predict whether this particular patient is going to respond to which type of medicine. And there are enough ample set of examples, ample medicines are there, tests are available. Common example, FLT3 inhibitors. Then even the most dreaded mutation, it is that is TP53 mutation. If any particular person is harboring that mutation, it can be familial also. So they are likely to develop cancers, and their cancer also is going to be, if they develop cancer, these are like aggressive cancers. So in that way, if it for that we need to study. And earlier days, almost 10 years back, these tests were not available easily in our country. Now we can say that these tests are easily available. Even the cost is also coming down, so it is more beneficial for the patient, and it is helping a lot in treating our patients.
Very rightly said, sir. We've talked a lot about the advancements in the cancer therapy. I'll just give you one account. We treated a patient of leukemia from Rajasthan. He was from a very far-flung place. So AIMS mein, whenever a patient used to get registered in Dr. Sameer's unit, the first thing he used to say, what? Bring 6 donors of blood. If you bring 6 donors, I know that you are committed towards the treatment of the patient. We are not going to charge you anything for the treatment, and we will register you. So that is his just benchmark. So when that patient got treated, he got cured, he realized that there was a big unmet need as far as transfusion medicine is concerned. So he came back to me 1 year later. He said that we have started a mobile transfusion van clinic, which is helping in the accessing the blood products at the remotest of the places in India. So just briefly a question from Dr. Sanyal, sir. So how has the improvement in the supportive care, like development of newer antibiotics, growth factor support, and transfusion policies have led to the improvement in the outcomes of blood cancer? Because we cannot skip this part whenever we are dealing our patients of blood cancer.
So you asked a very good question, very close to my heart, because I built the department from the scratch. Nothing was there. So there are 3 things is extremely important: hematology, hemato-oncology, and bone marrow transplant. Number 1, you have to understand few very basic things. Blood transfusion doctor, I'm using the word. That does not mean one doctor is sitting in the blood transfusion department and uska job kya hai? Surgeon is demanding 6 unit of platelet to be given. Uska kaam sign karke de dene ka. No. Now there is a MD course that is called Transfusion Medicine MD. So that is extremely important thing. And Transfusion Medicine MD is a subject itself. When we did our hematology training, we are part of that, our curriculum, it was covered. But now if transfusion medicine is totally separated out. Even our Indian Society of the Hematology Association, transfusion medicine is taken out. They have their own society now. So that is recognized as a separate department now. So transfusion medicine guys are taking care of everything. So 3-4 massive things has happened. I think the irradiated blood products, that is one of the very important things. They do a lot of therapeutic decisions. Because in Bombay, we get a lot of secure patients. RBC exchange. What we used to do in our DM days, in our KEM days, we have to take out some, seeing the hemoglobin and PCV, take out some blood, give some blood like that. So we do the RBC exchange. We call it a plasmapheresis. In our hospital, for the plasmapheresis, nephrologists are totally out of the service. Transfusion medicine guys taking care of all the plasmapheresis. Plasmapheresis means exchange of blood, the few of the blood disorders we do. And I'm very proud that my institute has 2 qualified transfusion medicine MD works with me. And that is why I'm very comfortably sitting with you and discussing and chatting with you. And today they are doing 2 stem cell collections. So that is the extremely important thing. We are already the recognized center of the DKMS and Therapies. We collect the stem cells and transport to the different part of the city, country, and the outside the country also we do. Recently, we did one stem cell product to Argentina recently. So that much equipped we are. Second, in hematology and BMT, very good infectious disease specialist. Infectious disease specialist does not mean just MD medicine trained. MD medicine, and then they are specifically trained in infection disease. And remember the antibiotic stewardship. I'm not talking about this thing little bit. In our country, our bone marrow transplant, Pawan will agree, Dr. Gaurav will agree, major point, we don't lose the patient due to our transplant technicalities. We lose the patient due to infection and the gram-negative infections. And that is the end of the story. Many times you go into abroad, you see the people are getting prophylactic antibiotic. हमारा देश में तो prophylactic antibiotic होता ही नहीं है. Everyone is resistant. And when I get a doctor patient high profile, I know that patient, that doctor patient गले में एक दिन हुआ, 5 दिन antibiotic तो खाता ही होगा. So this is the dreaded problem in our country. Antibiotic stewardship. In our hospital, antibiotic stewardship is followed very, very strictly. We are able to write antibiotic, but all antibiotic, higher antibiotic orders are monitored. And infectious disease specialist who is specifically trained in hematology. It is like a football. You have to play. You have to understand. Suppose you're a striker, you know, midfielder कैसे pass दे रहा है आपको, आप उसको convert कर पाओगे क्या नहीं? It's like a team game. So what she's thinking, my ID physician is Dr. Kirti. She's trained in hematology 1 year, and then she trained in infectious disease specialist in CMC Vellore for 3 years, and then I choose her to be part of our team. And we discuss a lot of things, and then we decide about the antibiotic. Sometimes we fought very badly, that I am not discussing here, but ultimately we come with a single plan, single solution, and move it. So these 2 things is extremely important to run a successful Haemato-Oncology and bone marrow transplant service you need to run.
Very well said, sir. So now we have to discuss about the CAR T-cell therapy that that everybody is talking about. It is a new kid in the block as far as leukemia, lymphoma, myeloma treatment is concerned. Dr. Gaurav is also working in the manufacturing of those therapy. I would just briefly ask, can you simply explain in very simple terms what is a CAR T-cell therapy and what are the challenges in its manufacturing, and how it has been a part of treatment of leukemias in the West for almost 6-7 years now, and what are the challenges in bringing, like, for most of the Western drugs which are launched, you can import it and start treatment even in India. But what are the challenges with CAR T-cell therapy in importing a drug which is already approved and available in the West, but we cannot use it?
Right. Thank you, Abhishek. So I think this is something which is very pertinent, and all of us need to discuss this therapy because this is a revolutionary therapy. This is a path-breaking therapy, and probably 5 years down the line, if we'll be sitting in any of such summits, probably we'll be discussing more about CAR T-cell therapy or cell-based or personalized therapies rather than the conventional way we are treating the blood cancers presently. So CAR T-cell therapy is something which is very interesting. The simplest way to make you understand is, हमारे बॉडी में जो इम्यून सिस्टम होता है So our strongest foot soldier of our immune system are our T cells. There are T cells in the body, T cells, B cells. T cells वही होते हैं जिनमें leukemia पनप जाता है whenever they have any aberrancy. So our T cells are our strongest foot soldiers, and they are constantly surveilling our body. If there is any microorganism, कोई bacteria है, कोई fungus है, कोई कुछ भी है, उसको identify करते हैं, kill करते हैं. Similarly, they identify cancer oncogenes cells also, that in our body, at any point of time, there are cells which, in the process of senescence, in the process of dying, they develop this potential of converting into a cancerous cell. Okay, so these T cells, they constantly do surveillance, and if there is any such cell which develops the oncogenic potential, they kill this cell and sort of remove it from the body, and that's why none of us sitting here, or majority of sitting here, don't develop a cancer. But when this surveillance mechanism is lost, which can happen because of a number of reasons, okay, then these T cells are not capable of identifying cancer, and that is how the cancer develops. So CAR T cell is, in simplest terms, sort of making your T cell capable of identifying the cancer and subsequently killing the cancer. The biggest success which has been achieved so far in CAR T cell therapy space is in liquid malignancies. Liquid malignancies मतलब जो blood के cancers होते हैं, and that too in leukemias and lymphomas, especially B cell leukemias and lymphomas, because of certain advantages of this particular malignancy. Okay, in the solid tumor space also someone mentioned about RCC. There is a CAR T cell drug which is approved for RCC, but large scale use is not there. But it's just a matter of time. This therapy will transform the entire oncology space. So CAR T cell is a very useful therapy. It is sort of educating our own T cells which have lost this identification mechanism. So make them capable of, by genetic engineering, of re-identifying the cancer or the target cell of interest and subsequently killing it. Now the problem is that this therapy, as Abhishek has highlighted, was first used almost a decade back, more than a decade back in US. Subsequently, because of the advantages of this therapy, got FDA approval, came into large scale use. But why it did not came into India and other resource limited setting was the cost, just like any other therapy. So the cost was prohibitory. The cost of this therapy still in US and Europe, majority of the centers is approximately 400 to 500,000 US dollars per patient. Okay, so that's sort of unimaginable in our country कि अगर हम उस cost पे किसी ऐसे patient को treat करना चाहेंगे, ऐसे disease को treat करना चाहेंगे जिसका annual incidence B cell malignancies का हमारे country में almost 80,000 to 100,000 new patients, including both pediatric and adult patients. So it's impossible. So the biggest challenge was to bring down the cost, and that's how these indigenous therapies have come in. We might be, a lot of us might be aware of one already approved CAR T cell like NextCAR, developed by Immunoact and Tata, which is commercially available at a very reasonable cost. Similarly, there are other groups also working. We are also working on the CAR T cell therapy, trying to come up with more advanced CAR T cell therapy, and also keeping this very important aspect that how to keep the cost. Now, किसी भी चीज की कॉस्ट कम करने में क्या होता है, अगर हम उसके सारे इंग्रेडिएंट्स को इंटरनली मैन्युफैक्चर करें, विद इन द कंट्री मैन्युफैक्चर करें, देन यू कैन कीप अ फुल कंट्रोल ऑन द कॉस्ट. अभी तक क्या था कि अगर कोई वायरल वेक्टर हमें करना है, वो इंपोर्ट करना है, उसकी कॉस्ट होती थी. जो भी बाकी के जेनेटिक कंपोनेंट्स हैं, प्लाज्मिड्स हैं, उसकी कॉस्ट होती थी. So what we have done, and not only us, other people also, we have tried to develop everything in the country. So we recently got approval for first lentiviral vector manufacturing unit in the country, isolated. So that gives us a lot of strength. जो चीज 20 लाख, 30 लाख, 40 लाख में हम import करते थे, that we are able to manufacture at 1.5 to 2 lakhs, 3 lakhs, 4 lakhs. So, and that's an important component. So these are the ways by which we are trying to bring down the cost. And once the cost is brought down and these therapies are made more efficacious, जो अभी challenges हैं existing CAR T cell के, उसको अगर हम address कर पाएंगे, तो I think in next 3 to 4 years this will come at the forefront, not as a salvage therapy which is currently the approach कि अगर patient को किसी को 2 बार 3 बार relapse हो गया है, they are considered to be candidates of CAR T cell. We want this therapy, this very effective therapy to come at the forefront, just front line or in first relapses. So this is how we can bring down the cost. And third was, what was your last question?
It has been utilized in West for a long
Yeah.
time. What was the challenges in procuring it?
I think the cost was the biggest thing, because these companies which are marketing it in West, they do not have their commercial interest in India just because of their costs. So whatever we have to develop it internally, and the momentum has already started. And as I said, it's just a matter of time. These therapies will be available for large scale use and at an affordable cost.
Okay. So, just quick question to you, Dr. Pawan. Do you think with the newer modalities of treatment, Sir has talked about CAR T cell therapy, we have now data for certain other type of immunotherapies to treat your blood cancers. Do you see a way forward where we can get rid of chemo and some of the more toxic therapies like stem cell transplant, which is curable, but it does have a lot of survivorship issues in the long run?
Yeah, so in recent years, if we see so many advancements have been occurring, and we see a lot of newer therapies. So what is the basically the advantages of targeted and therapies, and these are very selective, or the precision medicine immunotherapies. So one advantage is that they are more efficacious as compared to the previous therapy. That is why they are more effective in treating multiply relapse refractory malignant cases. Other is the side effects. So again, that is the very important thing, because conventional chemotherapy, if we see, it is mainly the side effects because of the mortality is happening. So if we cut down the side effect, and that side effect can be achieved only by having the target. So our medicine should be only specific to that particular target. So if we select and find out that target, and it is not possible for every patient to have that target. So, but if you see many of the cancers, almost majority of cancers we see, many targeted therapies are there, immunotherapies are there. So mainly it is, and these advances. So the way we were treating in past 10, 15 years, 15 years back, and the way we are treating these patients now in 2025, it is much more effective, much less side effects, and that's why we are delivering the outcome.
I think in the interest of time, it will be the last question, and I think it is a question for every one of you. The cost still remains an issue. Like Dr. Gaurav highlighted, I think even the Indian CAR T cells that we are utilizing in our practice, apart from the product cost and the supportive care cost, it still scales up to 45 to 50 lakhs per patient, which is a huge amount. Yes, we can bring down the cost, but how an effective public-private partnership can bring this success story, or we can improve upon the cost and the challenges and make it more accessible to the people who actually need it, because this kind of treatment probably can be afforded only by 0.5% of the Indian population. How can we make it more accessible?
One thing I want to highlight here is, even in fact, for the general population also through business world, that अगर हम देखते हैं, हमारे पास 5 कैटेगरी of patients हैं इंडिया में. One is government serving patient, everything, their treatment, their health is taken care by the government. दूसरे होते हैं गवर्नमेंट रिटायर्ड, जो कि CGHS, ECHS बेनिफिशियरी होते हैं, या और कोई पैनल हो जैसे ESI सर्विंग जो प्राइवेट कंपनीज हैं. तीसरा होता है इंश्योरेंस, और चौथा होता है आउट ऑफ पॉकेट, जो कि अपनी कुछ प्रॉपर्टी, जमीन या कुछ एसेट्स बेच के अपना इलाज कराते हैं. और फिफ्थ होता है जो कि जिनके पास कुछ नहीं होता है. सो ईदर दे, एंड मेजॉरिटी ऑफ पॉपुलेशन इज दैट, जिनके पास कुछ नहीं है. सो उनके पास ऑप्शन क्या होता है, या तो गवर्नमेंट हॉस्पिटल में जाएं जहाँ पे सारी फैसिलिटीज नहीं है. इवन इफ फैसिलिटीज आर देयर, दे आर लॉन्ग क्यू, पहुंच ही नहीं पाते हैं वो डॉक्टर. या फिर क्राउड फंडिंग. अगेन क्राउड फंडिंग हमारे यहाँ पे नहीं होती है. तो हम ये सोचते हैं कि हर चीज जो है कॉस्ट कम हो जाए उसकी, कि कंपनीज जो है कॉस्ट कम में दें, वो करने वाले नहीं है. गवर्नमेंट फैसिलिटी में हमें जो है लेस कॉस्ट में मिले, या प्राइवेट सेक्टर में हमें हेल्थ लेस उसमें मिले, वो भी नहीं है. आप यहाँ पर भी देखिए, किसी के पास इंश्योरेंस अगर होता भी है तो कितना होता है, मोस्टली 5 लाख का कवर होता है, उसमें कुछ नहीं होता है. किसी भी प्राइवेट हॉस्पिटल की अगर आईसीयू में हम एडमिट होंगे, 1 लाख रुपए पर डे का खर्चा है, जो कि इससे कवर नहीं होता है. इम्यूनोथेरेपी, टारगेटेड थेरेपी, किसी सो एटलीस्ट इवन कोविड ने हमें सिखाया, बट फिर भी मुझे लगता है कि नहीं सिखाया. अभी भी मेरे पास ऐसे पेशेंट आते हैं जो कहते हैं इंश्योरेंस है ही नहीं जी, एंड दे कैन वेरी वेल पे द इंश्योरेंस प्रीमियम. आपको 10-15 हजार रुपए पर ईयर पूरी फैमिली कवर हो जाता है आराम से, इवन 50 लाख का कवर भी मिलता है. सो थ्रू मीडिया एंड सब कुछ इनकी वजह से मैं ये हाईलाइट करना चाहता हूँ कि एटलीस्ट जो बाकी लोग जो करेंगे एटलीस्ट वी शुड आउट डू आवर जॉब, कि हम तो अपना करें, एटलीस्ट इंश्योरेंस कवर होना चाहिए. और बाकी जो क्योंकि कॉस्ट कम, हेल्थ केयर कॉस्ट अगर हम देखते हैं तो ऑलमोस्ट एनुअली बढ़ती जा रही है.
I think start insuring at an early age so that you have to pay less premium. That is the message. And I think the time is up. I would really like to thank all the panelists. And if there are any questions from any of the audience, we would love to answer. Yes. नहीं मैम, मल्टीपल माइलोमा जनरली इट इज नॉट अ जेनेटिकली ट्रांसमिटेबल डिजीज. ब्लड कैंसर्स, ल्यूकीमियाज वगैरह में जैसे डॉक्टर पवन बता रहे थे कि एक कुछ म्यूटेशंस होते हैं जो अनुवांशिक होते हैं, जिसको कि फैमिली टू फैमिली दर फैमिली ट्रांसफर हो सकता है. बट मल्टीपल माइलोमा जनरली जेनेटिक नहीं होता है. ज़्यादातर केसेस में किस वजह से माइलोमा होता है हमें पता नहीं होता है, जिसको हम इडियोपैथिक टर्म बोलते हैं. सो इसमें फैमिली मेंबर को कोई रिस्क नहीं रहता है. Yes, ma'am. There are so many oral tablets. I think the biggest success story I think everybody can concur is tablet imatinib. That is used to treat CML. CLL may we have ibrutinib, acalabrutinib, which is used to treat lung cancers. We have excellent oral tablets with for certain targetable mutations, which patients can take at home and they can have a very comfortable life, good quality of life. So there are so many tablets which are available. अच्छा है मैम, but I still prefer to use imatinib because it is time tested, very well tolerated. In certain subsets we do use slightly more side effects than imatinib, ma'am.
That's one.
I would like to make a small correction. So there's nothing like stem cell therapy which is approved by the government. When we talk about stem cells, it is stem cell transplant which is the approved treatment. Now for stem cell transplant, just like for many other diseases, if it is acquired like blood cancer or something, or severe aplastic anemia which is acquired, it is fairly covered by insurance. But for some inherited disorders like thalassemia, sickle cell disease, or some other inherited disorders, majority of these insurance do not cover it. So it is out of pocket. But now there are a lot of good CSR initiatives which have been initiated by central government and state governments, which do cater these patients as well. And the second question was about CAR T cell therapy. So at this point of time, it is not covered under sort of by majority of insurances. It is not covered. But yes, I think once the efficacy of this treatment is established, large scale usage is there, then probably it will be covered by a lot of our government agencies as well as the private insurance players also. So that's no, I totally agree with you, and it's not only about this particular. It's also about like gene therapy for thalassemia and sickle cell disease, which we are trying to come up at a cost, affordable cost, where majority of patients can avail it. And but subsequently, you need a lot of advocacy. So just the way we have been able to bring the transplant for thalassemia, sickle under the gambit of CSR initiative, Probably down the line we'll be able to bring these therapies also under various CSR initiatives by government and PSUs.
Just one last word. I think there needs a big overhaul in the India's insurance policies. If we do mention about high dose chemotherapy and stem cell transplant, there are a lot of companies which reject the insurance. There's a big challenge. Similarly, I mentioned about there are oral tablets which can be taken to treat cancers. So there is this tablet called as lorlatinib. It is especially used to treat certain lung cancer patients. You do not need any admissions for that, but it costs 1.2 lakh rupees per month. But it's a very effective therapy. Patients live for even 5 years without progressing. So imagine how none of the insurances are covering these certain effective therapies which are prescribed from the OPD basis as a reimbursement. They don't get reimbursement even after paying out of their own pocket, and they apply for it. They say that OPD is not reimbursed. So whenever you're applying for insurance, these are the important questions you need to ask your insurance agent: what is covered and not covered. I think some of the companies have started, some of the good insurances have started covering the stem cell transplant, even if you write it on paper, but still majority of them don't cover it. They put the entire thing under the gamut of this newer therapies or targeted therapy, immunotherapy. There is a very small line written in the clause which you don't read when you are insuring, that this is not covered. Even if you have taken a 50 lakh insurance, the limit of coverage for immunotherapy is just 5 lakh. So patient says that, okay, doc, I have a 50 lakh insurance, go ahead and start the treatment. In the third cycle only, his insurance limit for that drug is over. So that is why there should be a very black and white line defined what is covered and what is not covered. And India's health insurance policy needs a big overhaul. And I think a lot of you people sitting here, you guys are the ones who can probably initiate and change it.
Done. Thank you. Thank you so much.